So now let's discuss diabetes in pregnancy. It's defined as fasting blood glucose greater than 105 after 24 to 28 weeks of gestation. This diagnosis is made at the 24 to 28 weeks of gestation, so all the pregnant ladies should be screened for gestational diabetes at 24 to 28 weeks. So basically there are two tests for the diagnosis. First one is a screening test and second one is diagnostic test. Screening test is also known as GCT, that is glucose challenge test, and diagnostic test is known as glucose tolerance test. So in screening test, what we do is we give glucose, 50 gram glucose to the mother and check her glucose after 1 hour. After, if the blood glucose is greater than 200 gram after 1 hour, then this is a diagnosis of the gestational diabetes. But if after 1 hour her blood glucose is greater than 140, not 200, then we need to confirm the diagnosis with another test which is known as glucose tolerance test. What we do in glucose tolerance test, basically in glucose tolerance test we give 100 gram glucose and check her glucose after 1 hour, 2 hour and 3 hours subsequently. First we check glucose level, fasting glucose level. If the fasting glucose is greater than 105, then this is a diagnosis of diagnostic for gestational diabetes. If 1 hour is greater than 190, 2 hours greater than 165, and 3 hourly it should be greater than 145. If any of the if two of these four criteria is met, is fulfilled, then we see that it is a diagnosis of the gestational diabetes. Alright. So for the management of gestational diabetes, first line management is diet and weight loss. This is the first line management. If the blood glucose is still not controlled, then we start second line like insulin and metformin. Both the insulin and metformin has similar efficacy. We can start any of the two. Alright. So there are some conditions associated with gestational diabetes like macrosomia and shoulder dystocia. What happens in macrosomia? Macrosomia is basically defined is when the fetus weight is greater than 4.5 kg, and the risks for this are gestational diabetes and increased maternal weight. And macrosomia is associated with shoulder dystocia. What is shoulder dystocia? In shoulder dystocia, there is a turtleneck sign, which is in which fetal head goes back into the pelvic cavity. Once it comes out and then goes back into the maternal pelvic cavity. This is known as turtle sign. For the management of shoulder dystocia, we do a maneuver which is called McClober's maneuver, in which maternal legs are flexed onto the abdomen and then suprapubic pressure is applied. In most of the cases, this maneuvers work and baby delivers easily. Other conditions like Erb's palsy and clavicular fracture are also associated with shoulder dystocia in case of the macrosomia. But luckily, both these conditions are self-resolving, and all we need to do is reassurance and observation if any of these conditions like Erb's palsy or clavicular fracture are present. Another condition which is called pubic symphysis diastasis, and this there is suprapubic pain which varies to back, hip, thigh and legs, and this pain is exacerbated by walking. We manage it conservatively with painkillers. This will resolve with time. You all need to do is give painkiller. Last condition which is associated with gestational diabetes is fetal hypoglycemia. It's basically due to the hyperinsulinemia from beta cell hyperplasia. When fetus is inside the mother's womb, due to the increased level of the glucose, beta cell hyperplasia occur, which increases insulin level. Then right after delivery, hyperglycemia is no more present, so the excess insulin results in hypoglycemia in newborn. Alright, this is all about diabetes in pregnancy. Gestational diabetes, how we diagnose it, two different types of tests, OGTT, OGCT, and then the management and the complications like macrosomia, shoulder dystocia, and suprapubic symphysis, diastasis, and Erb's palsy. All these are very important. Next is placental abnormalities, and first one is placental abruption. It's basically associated with certain conditions like constriction of the placental vessels, which results in ischemia of the placental vessels, and sudden abruption conditions like chronic hypertension and preeclampsia and smoking and cocaine use. All these are associated with placental abnormalities like placental abruption. It's very painful. It presents with painful bleeding, and bleeding could be heavy or mild. If it is concealed, then obviously the bleeding will be mild. If it's not, then heavy bleeding with sudden severe pain. In this case, the uterus is firm and tender with high frequency contractions. In this case, we need to induce labor with artificial rupture of membranes and give oxytocin. So, in uterine rupture, there is heavy bleeding, abdominal pain, tender and firm uterus. We need to induce labor with artificial rupture of membrane and oxytocin. Second condition is placenta previa. Placenta previa present with painless bleeding, abruption with painful bleeding, and placenta previa with painless bleeding after cervical manipulation like intercourse or digital examination. Its diagnosis made on the basis of ultrasound, which shows placental tissue is cervical os. Luckily, in 90% of the patients, placenta previa resolves. How it resolves? Due to the cervical dilation with time and due to the enlargement of uterus throughout the pregnancy, placenta previa resolves. It moves away from the cervical os. But if symptomatic, then we need to do inpatient management for hemodynamic stability and plain elective C-section before the onset of contraction. We need to do elective C-section before the onset of contraction in case of placenta previa and also in case of vasa previa. So what is vasa previa? Vasa previa is a condition in which fetal vessels are present at cervical os. In placenta previa, placenta is present on the cervical os. In vasa previa, fetal vessels are present at the cervical os. It presents with minimal painless vaginal bleeding. Why minimal? Because this blood comes directly from fetus, not mother. And fetus, we know fetal total blood in fetus is less, so there's minimal bleeding. Minimal painless vaginal bleeding with rupture of membrane or contractions. Due to the fetal loss, there is fetal bradycardia. This blood is coming from fetus, so which cause fetal distress and fetal bradycardia and sinusoidal pattern on ECG. About the management depends upon the time of the diagnosis. If it's present before 30 weeks of gestation, observation is done in high risk ward. If present after 34 weeks of gestation, then cesarean section is done before the onset of contraction, just like in placenta previa. Other conditions like placenta accreta, increta, and paracreta, in which endometrium invades myometrium, it occurs at the scar site in previous cesarean section or in the dilation or curettage. Basically, there is already a scar present on which, on that place, endometrium invades into the myometrium, and depending on the depth of invasion, we differentiate as placenta accreta, increta, or paracreta. In accreta, endometrium penetrates only superficially to the decidual layer. In increta, it penetrates myometrium, and in paracreta, it goes beyond myometrium. Alright? So, in placenta accreta, it presents with firm uterus and severe vaginal bleeding postpartum. If there is severe persistent postpartum hemorrhage, then we need to do hysterectomy with placenta in situ in case of placenta arterita. Next one is uterine abnormalities. So in conditions like prior cesarean scar or in myomectomy scar, there is increased chance of uterine rupture. It presents with sudden severe abdominal pain and heavy bleeding, and fetal station is lost. In uterine rupture, fetal station is lost. And fetal parts are palpable on per abdominal examination, not per vaginally. On vaginal examination, no fetal parts are palpable, but per abdominal examination, fetal parts are palpable. In uterine inversion present with severe abdominal pain and smooth mass protruding from vagina. If the placenta is still attached to the uterus, then there is chance of hemorrhagic shock due to severe bleeding. For management, we discontinue oxytocin because it will lead to more contractions and more inversion of the placenta of the uterus. So we need to stop oxytocin, and we do urgent manual replacement of the uterus without delay. If it fails, then we do laparotomy to prevent ischemia of the uterus. In uterine rupture, painful bleeding, and then we discussed uterine inversion, in which smooth mass coming from vagina and bleeding if placenta arterita is present. Then uterine atony. In uterine atony, there is enlarged bogey uterus with severe bleeding from open viscera due to insufficient uterine contractions. The uterine is completely smooth, there is no contraction, and vessels are open, which leads to severe bleeding. And causes of uterine atony are like overdistension, as in twins, polyhydramnios, and macrosomia, or overcontraction, as in prolonged labor. And management of uterine atony is done by bimanual uterine massage and drugs like oxytocin, which is a first-line drug. Other second-line drugs include misoprostol, methyl ergonovin, which is a potent vasoconstrictor. It is contraindicated as hypertension and heart disease. If the patient is already a patient of hypertension or heart disease, then we avoid this drug. Third drug is carboprost tromethamine. It is contraindicated in asthma because it causes bronchospasm. And fourth one is tranexamic acid. It is contraindicated in case of hypercoagulable state. So before starting certain drugs, we need to look out other comorbidities in patient, whether he is asthmatic or hypertensive or any heart disease already present in patient. Then we select alternate drug in patient.